First, we would like to invite Dr. Preeta Nair. She is at present working as consultant in Department of Oculoplasty and Orbit, Chaitanya Eye Hospital, Palarivattam branch, and she completed her fellowship from Shankara Nethralaya, Chennai, and she did her senior residency 1.5 years there. After that, she joined with us. Over to Preeta for your talk.
Thanks, Jimmy. Yeah, I'll be talking about management of orbital emergencies, know the signs and act fast. So these will be the categories I'll be dealing with: infection, trauma, inflammatory and vascular cases. What is an orbital cellulitis? So it's an orbital inflammation that involves muscle fat which is caused by pathogenic organisms. It's a potentially life and vision threatening situation. Most common pathogens are bacterial, fungal, and rarely tuberculosis and parasitic are also been reported. Most common source of infection that we usually see are rhinosinusitis. Patient usually presents with severe periorbital edema with painful proptosis and ophthalmoplegia and decrease in vision. They also give associated signs of symptoms of fever, sinusitis, trauma, and surgery. An urgent imaging is necessary when you see such a presentation, and start the patients on empirical IV antibiotics, which should cover a broad spectrum, and also start on systemic corticosteroids. These patients we can also take an ENT or a neurosurgeon consult based on the case. So this is a 11-year-old boy who had presented with left eye prominence, who was associated with pain and headache since 4 days. An urgent MRI with CT cuts was advised, and the MRI picture showed a well circumscribed oval soft tissue lesion in the medial orbit displacing the globe, and a post contrast rim enhancement with central necrosis. This was suggestive of an abscess. The patient was taken up for an emergency abscess drainage through transcaruncular incision, and the capsule was also excised. And simultaneously, the patient also was started on a broad spectrum IV antibiotics. The thing which you have to keep in mind is the patient should be on a kept on a close monitoring. The vision, pupil, extraocular motility has to be checked. These are the indications for drainage. So in another case of invasive fungal infection where the patient also presents with similar orbital cellulitis, it's an aggressive life-threatening condition. If it's identified and treated early, it is curable, otherwise it's going to be fatal. An urgent imaging is recommended, followed by, to confirm the diagnosis, biopsy or a culture. So this is another 54-year-old male who had presented with severe proptosis and painful ophthalmoplegia. He had a history, he was a high diabetic. On imaging, this was the picture. You could see a peripherally enhancing lesion in the left medial orbit, which is suggestive of an abscess. And in the T1 weighted imaging, you can see a non-enhancing lesion in the supranasal orbit, which is suggestive of necrosis. So the lesion is extending till the posterior orbit up to the apex, beyond the apex. So in such a case, this patient had to undergo exentration because in the left orbit, because the lesion was extending beyond towards the brain. And the right orbit also you could see the lesions. So this patient, an aggressive surgical debridement was done and was also started on intravenous amphotericin B therapy. Transcutaneous retrobulbar injections are also recommended. A close vision and pupil monitoring is important in all these cases. Another case where we can, which is a site and life-threatening emergency, is periorbital necrotizing fasciitis. Usually the cases present with 1/3 cases present with bilateral involvement, and trauma, surgery, immunosuppression are the predisposing factors. Diagnosis is usually clinical. So these patients will present with a violaceous discoloration of the skin with periorbital swelling, which presents within 24 hours, and then it goes into gangrenous formation within 96 hours. Management is important, where these patients are started on high-dose IV antibiotics, which cover the broad spectrum area, and an early surgical debridement is necessary to remove all the non-viable tissue. A close follow-up followed by repeated debridements may be necessary. You can plan reconstruction later once the infection settles. these complications are expected. So emergencies related to trauma that you see most commonly in your setup will be blood, fracture, orbit, intraorbital foreign bodies, globe subluxation, all these injuries and animal bites. One second. So a blowout fracture, is it an emergency? These patients usually present with complaints of diplopia, inophthalmos, infraorbital hypoesthesia with associated complaints of nausea, vomiting. And when such a patient presents to you, it's important that you advise emergency CT orbits. And if you see an entrapped muscle or orbital fat, it's important that it has to be repositioned back. The entrapped muscle has to be released and the orbital tissues has to be restored back into its position. So this is a case where a 6-year-old boy had presented with complaints of vomiting and diplopia. Urgent CT orbits, we could identify the entrapped inferior rectus muscle, and the patient presented with difficulty in elevation also. So we took him up for an urgent orbital fracture repair. The muscle was released and put in position. So this was the outcome post-operatively. Another condition is in traumatic cases, patient can present to you with enophthalmic picture. So it's important that you advise CT, and to our surprise, this was the condition. So the globe was subluxated into the maxillary sinuses because of a large blowout fracture in the floor and medial wall. So these cases were immediately taken up for exploration and repositioning of the globe, followed by the fracture repair. This is another emergency where you can see this child presented with spontaneous subluxation of the globe, where the globe is displaced beyond the rim, and there is always a risk of tethering of the optic nerve. So mostly these cases can be traumatic or spontaneous or self-inflicted. Cases of thyroid orbitopathy, shallow orbits, space involving retrobulbar mass and lax lids, severe craniofacial trauma are the predisposing factors. So management will be, you have to reposition it back into the orbit, back into the normal position with a Say's manure. Another common condition that you see is types of injuries like globe injury, lid abrasions, and canalicular tear, trauma to the extraocular muscles. So when you suspect an animal bite, you have to have a thorough wound cleaning and rabies prophylaxis in case of dog bites. Do a good thorough exploration and a surgical reconstruction. In cases of intraorbital foreign bodies, we can divide them into organic, inorganic. These cases, if the patient presents with an intense inflammation, purulent, or a cirrhosis, an urgent removal is recommended. These can be taken up for exploration and removal. These are the indications for a surgical removal. If the foreign body is superficial, sharp, if it's contaminated, organic, or most importantly, if it's causing a functional deficit, yes, it has to be removed. Various inflammations in orbit that you commonly see are like thyroid-related optic neuropathy, where you can expect an emergency in case of this thyroid optic neuropathy, which presents at 5 to 8 cases of TED. So these cases, if you go ahead with an imaging, you can see such a picture where you can see the enlarged ocular muscles, and that is compressing the optic nerve at the apex. So a picture where you see an apical crowding or an optic nerve compression, that is important because it's going to be vision threatening for the patient. So always assess vision, color vision, pupil, VEP fields in these cases, and if it's all deranged, take the patient up. The patient has to be started with IVMP 1 gram for 3 days, and then reassess the response. And patient, if is showing a good response, you can start on with a pulse therapy of steroids for 6 weeks along with radiation therapy. Or if there is a derangement in the vision, the patient has to be taken up for an emergency orbital decompression surgery. Another important condition is an orbital compartment syndrome, where retrobulbar hemorrhage where the acute bleed can cause compression in the optic nerve, and which is side threatening. So an immediate orbital decompression, lateral canthotomy cantholisis can be done in these cases, and the patient can be started on steroids and anti-glaucoma medications. So timely recognition of orbital emergencies, prompt imaging and diagnosis, appropriate management, delicate and meticulous surgical technique are important, along with a multidisciplinary team approach. Thank you.
That was an excellent talk, Dr. Preeta, and excellent documentation of external photograph, MRIs, and rare cases also, globe subluxation and globe missing. Those cases that not so common cases that we people usually most of us are first time means see the means seeing the such kind of cases and how to manage such cases. Your means information was very much means helpful to us in our coming practices also.